Welcome to the Neurocrush immersion. In this episode, we are going to talk about the pain of conscious experience. And we have with us a very eminent neuropsychiatrist and researcher from the National Institute of Neurology and Neurosurgery in Mexico, Dr. Jesús Ramírez Bermúdez. Welcome, Dr. Jesús, and thank you for joining us on the podcast. Would you like to tell us a little bit about yourself?
Yes, thank you very much, Dr. Krish. And about myself, I am a clinical neuropsychiatrist working in the National Institute of Neurology in Mexico. And I've been working for about 25 years already with patients with brain disease, but specifically forms of brain disease that make that several kind of pathological processes leading to disturbances of the mind, behavior, problems like psychosis, catatonia, cognitive dysfunction, and so on. And my own research has been focused in the last years on the problem of autoimmune psychosis, which I think is an important discovery in the field of cognitive neurology and neuropsychiatry, because years ago we used to see these patients, and it was really perplexing for us to try to find out what was the problem behind their illness. Some would think it was just a form of primary psychosis. Other clinicians would think this was a disease caused by viral encephalitis. And later on, we discovered that it was an immunological problem mediated by antineuronal antibodies. But the important thing is that it leads to immunological treatment. So now we have some hope. And I am telling you this because in a way, my career has focused on the scientific field, but working with the scientific problems and the clinical realities, I also found out that these perplexing cases would motivate me to make a reflection on it. So this kind of personal reflections led sometimes to literary work on one hand, and also to an interest for the history and philosophy of our own disciplines. So broadly, that is my kind of work.
Wonderful. And the papers that we're discussing, especially this one, the clinical narrative and the painful side of conscious experience, which you published in Philosophy Psychology, very reflective of that interest. You know, a lot of people have fear and stigma when they are experiencing hallucinations and other mental health experiences which are painful and challenging. And openly sharing these experiences with clinicians can be quite challenging for people. What specific strategies or clinical approaches can you derive from the trans-epistemic dialogue that will help in this? And can you please explain also to our listeners what you mean by trans-epistemic?
Yes, thanks. It's an important question for me because perhaps you agree that as clinicians in the field of mental health, we need to speak many languages. So if you allow me the expression, for instance, myself, I need to speak the language of clinical neurology, which goes into the realm of the brain and neuronal functioning and biochemistry and neurophysiology and biology and biophysics and so on. That is a kind of discourse that I need to understand. But also, we need to speak the language of interpersonal realities, mental states, desires, thoughts, emotions, and within their specific context. Because when I'm with a person who has, for instance, a state of paranoia or a state of depression, to them, these are not abstract realities, right? Instead, for them, these are realities that are embedded in their own life histories, in their own social context, and so on. So we need to speak the language of sociology, the language of anthropology, the language of psychology, the language of psychopathology. So I would use the term, we need to be epistemic multilinguals, so to speak, right? Because we need to speak many epistemic languages, languages of knowledge, the knowledge of interpersonal realities, the knowledge of the brain, and so on. And when we do this, I think this is an interesting approach, different from the reductive approach, which is common in the field of neuroscience, right? We listen to the radio, to the in the internet, and by reading books, and we always read things like you're not making your own decisions, it is your brain making the decisions, the neurons control your decisions, and so on. So that kind of reductive discourse, which is very common in the neurosciences, I think it is unhelpful in a way, because what neuroscience can give us is an understanding of how the brain works with the specific rules for that kind of system, a biological system. But I think that the hard question that is being discussed by philosophers and people in the fields of culture is, how do these billions of neurons integrate their functioning to create the realm of psychological behavior, right? And because we are psychological agents, so to speak, who think and have desires and also are responsible for their own actions. So the difficult question is, how do we pass from the level of these physiological processes to the level of psychological behavior? That is the question. That is the important scientific discovery to be made. And so I don't relate to the kind of reductive discourse that is common in the neurosciences, but instead I call for a systemic view. The systemic view uses the resources of neuroscience, but also acknowledges that when we analyze systems like the brain or the body in a more integrated way, there are emergent properties. There are properties of the whole system, but not properties of the parts. So, for instance, myself as a system, a biological system, has the emergent property of being a person, of having consciousness, of having thoughts, desires, projects, and so on. But these are properties of the whole system, not properties of the specific part. Like writing a book is not the property of one specific neuron or one specific cell in the liver or the heart, right? It is the property of the whole system. Reading a book, writing an article, having a conversation in this podcast is the property of the person. So the transepistemic dialogue is an opportunity to acknowledge all the dimensions in this reality, which is one unified reality, but it has many aspects: a sociological aspect, a neurobiological aspect, and so on.
I understand. Thank you. When we listening to someone narrate what is a painful conscious experience that they've gone through, we also have to distinguish between those that are lived experiences, those that perhaps are imagined, and sometimes even those that are made up. due to either confabulation or very overactive imagination, or sometimes even because there is a certain amount of malingering going on. How do you distinguish genuine painful conscious experiences from these other types of experiences? And how should that influence how you deal with the problem?
That is a great question. I don't think we have a direct way to measure that objectively, because we don't have like a thermometer, like a kind of instrument to measure the consciousness of the other, right? That is the hard problem of consciousness, that we cannot pass from the level of scientific objectivity to the understanding of the subjectivity of the others. I can only have a full approach to my own subjective experience, but not the subjective experience of the other. So I have to listen to the other. I have to understand their own words, their own forms of symbolic expression. But after saying that, having said that, I think that we have a set of clinical capacities, a set of clinical tools to start making that differentiation that you say, and that is very important as well. Because of course I need to acknowledge if my patient has a painful consciousness, so to speak, form of emotional or mental pain that comes from a lived experience through their history of interactions, as opposed to a painful state of consciousness that comes, for instance, from a hallucination or a delusion, right? It is a completely different approach. And also, you were telling the possibility that some people can fabricate or manipulate their narratives to create a false history. I don't think we have a specific tool. I think we have a set of a set of mental tools. But the most important for me would be to engage as long as possible with the person through the interpersonal process of understanding. And also, of course, we need to make some investigations through the relatives of the patient and their loved ones to have a bigger picture, because I don't think that in psychiatry or mental health more broadly, we should be naive about this kind of problems, because we want to help our patients in a truthful manner, but also in an effective manner. So it is very different approaching someone who has a state of depression because they have been the subject of violence in their families, for instance, and it's a very different approach from those who are having, for instance, a state of suffering related to delusions of ruin or nihilistic delusions, in which I should not take at face value the content of the discourse, but instead make a clinical approach to find out if these are truly delusions, not in order to reduce the patient to a psychotic person or whatever, but in order to help the other in an effective manner, right?
Absolutely. And I understand the challenge of making these distinctions and the importance of using all the different tools that we are empowered with clinically to try and see whether we can make the distinction. Now, as an experienced clinician, I'm sure you've worked with people for long periods of time. And one of the things in working with people over the long periods of time is that the narrative can evolve, change, and can be quite dynamic. How does one deal with that? Because, the dynamic shift in the narrative could affect your diagnosis, it could affect the way you're perceiving the patient, your ability to empathize with the patient, your experience of this.
Yes, I totally agree with you. And I think that when we speak about the cognitive capacity of our patients, we often use the word cognitive flexibility, right? We think that a measure of mental health is this capacity for cognitive flexibility, allowing for updating our own beliefs, our own strategies to solve a problem, and so on. But that also goes for ourselves, right? We need to remain flexible and not going to the kind of rigid and stereotype mindset that is often criticized by society when reaching some kind of doctors that are very dogmatic, right? So we don't want to be that kind of doctor. We want to be a kind of clinician that is open to experience and continuous learning. And that means sometimes that we need to swallow the hard pill of learning things that are sometimes distressing or unsettling. And for instance, I remember a case of a person many years ago. It was a patient with a state of dementia, a very severe form of amnesic disorder with executive dysfunction and so on. He was like 50 years old back then. And we discovered in the process of the hospitalization that this man had, in fact, nocturnal seizures because he had a form of frontal lobe epilepsy. Now, I am speaking to an expert in the neuropsychiatry of epilepsy, so please correct me if you want to come in a moment. But as you know, frontal lobe seizures sometimes can happen in the middle of the night, like in the phase 1 or 2 or 3, especially in the second phase of slow wave sleep. So this person was having a lot of seizures. We only found out through the polysomnographic study of the case. And also we made molecular imaging of his brain, in which we saw that he had really a severe form of frontal lobe hypometabolism as a result of a chronic state of suffering from frontal lobe seizures. So it was a severe case. We provided an effective therapy. The patient recovered completely from that state. So it was a reversible case of dementia. But the problem is that this happened many years ago. And in the next years, I had the opportunity to be the clinician of this man and his own wife and his son. And I found out that this family was having a lot of conflicts, family conflicts, and they were engaging in a lot of anger and resentment with themselves, but also with the clinicians. So every consultation was a very distressing consultation because they would, I was expecting some gratitude because in my own disposition as a clinician, I saw myself as someone that had provided recovery of the case. But instead of that gratitude, I received a lot of anger and resentment and so on. So this is what I mean about your question when I say that sometimes the narrative of the case changes abruptly. In the first episode of this history, it was a neuropsychiatric history of frontal lobe dysfunction and epilepsy and so on. But the next episodes were about a family dysfunction, a lot of psychological distress, a lot of resentment and so on. So the mindset of the clinician must be open to experience, and of course, we don't need to take this personally, right? I mean, these people was having a lot of distress, and I don't need to feel myself like a hero that has been betrayed by their patients. Instead, I need to remain open to contemplate the situation, to make a rational approach to it, and to provide some companion to these people in distress who is looking for help in my own clinical practice. So sometimes the histories don't evolve as we wish, but we still need to remain focused and rational and compassionate, even if it's difficult at times.
Absolutely. That is such a wonderful example of how we have to balance hard science with human experience, and how the lived human experience affects people. I have a related question, which alludes both to this and what you said about autoimmune neuropsychiatry, which is your area of interest. So on the one hand, we have all these wonderful advances in neuroscience, which help us understand where these symptoms are coming from and why people have these symptoms. But they are very reductionist approaches. It's a very reductionist understanding that we have. On the other hand, we have this opportunity of patient narratives and this, the painful the pain of conscious experience that the patient is going through, which can be quite dynamic. How do you resolve these two as a clinician? How do you put these two together? And once again, I have the question to you, in what direction is the relationship? How much does the biology affect the pain of conscious experience? How much does the pain of conscious experience influence the biology?
Exactly. So that's why initially I was saying that we need to speak many languages, right? Many epistemic languages. So we need to delve into the problems of neurobiology, but also the problems of psychology and culture and so on. Because each case presents us with a different picture. Some cases can be approached completely through a reductive approach, because sometimes the problem is really epilepsy and nothing more, right? Or an autoimmune disorder and nothing more. But I think that most of the cases involve different degrees of biological factors, cultural and sociological and historical factors, and also psychological factors. So the clinician needs to be aware of this in order to make a systematic approach to each of these realities through the resources that are needed in each case. So most of my cases of autoimmune psychosis resolve completely with immunotherapy. But I am thinking now of a person that I treated, and she's a wonderful person. But unfortunately, she had an autoimmune encephalitis, an anti-NMDA receptor encephalitis, which led her to a state of catatonia and severe cognitive impairment with a lot of psychotic symptoms. And she recovered completely of that state after immunotherapy. But later on, we saw that her personality had changed in a way in which the main symptoms were this severe emotional dysregulation, leading to hostility and aggressive behavior, and sometimes self-injury, even suicidal attempts. And we found out that previously in her history, she had suffered from many forms of abuse, right? Early in her life. So this is a mixed case or a hybrid case in which we have two factors that are both completely real and relevant because the antibodies are objective. The antineuronal antibodies are objective, and they need immunological treatment, which was necessary and helpful. But the encephalitis also changed her neurobiology in such a way that some psychological problems that were there before, the response to abuse, the emotional problem, and so on, became even bigger in magnitude after the encephalitis, because the abuse happened years ago, but she didn't have this kind of clinical symptoms like emotional dysregulation and so on before the encephalitis. So it is a mixed case from my perspective, and we need to treat her with maintenance treatment for the encephalitis with rituximab, but at the same time we need to provide a psychotherapeutic approach, which myself I tried to provide. And after many years of this challenging case, I think she's going through a phase of inner peace and more. Now I think she has more emotional balance, and her emotional approach to her own family has changed in a positive way. But it wouldn't be possible without the resources of psychotherapy. I also use the resources of pharmacological approaches for her, and it has been helpful, but after many years. So what I used to say to my own fellows and residents and colleagues is that our patients don't read the books. They don't behave as supposed reading the book.
Yeah.
The book speaks about a case of anti-NMDA receptor encephalitis, but it doesn't say anything about what if that person previously had any form of childhood abuse and so on. So these are hybrid cases. Medicine is like that. The mental health field is like that. So I think that we always need to acknowledge that reality and systematically investigate those dimensions, because otherwise we will have a lot of blind spots, which is the problem, I think, when mental health professions become ideologies, like anti-psychiatric ideologies, or also within the field of psychiatry, some clinicians become very reductionist. And that is a problem as well.
Absolutely. If I can bounce something off you, one of my very interesting patients with Lewy body dementia with complex visual hallucinations used to see little children playing football around him. And when I asked him, how did you fall? He'd say, they're playing football and I tried to kick the ball. And, that's when I fell. So his repeated falls were explained by this, but his experience was not a painful one, it was a happy one. He saw kids playing football. I had another patient with the same condition, Lewy body dementia, whose complex visual hallucination was someone having sex with a spouse in the neighboring bed. And that was, as one could understand, tremendously painful and would make him extremely angry. Now, the biology of having a complex visual hallucination is pretty much the same, one would presume, in both patients who have a diagnosis of diffuse Lewy body dementia. What do you think makes one experience painful and the other happy? Is it past experience? What is it?
That's a wonderful question, because, I take many points here. The first one is that suffering is not necessary for us to make a rational decision to diagnose mental illness, because sometimes mental illness can involve even these states of joy and happiness and so on, which are of course not pathological in themselves, right? they are normal emotions, but in some contexts, after frontal lobe injury or in the context of bipolar disorder and so on, they can appear in such a way that they can be problematic. And the example that you put is perfect, because the man is very happy looking at children playing football, but the result is a fall that could lead, of course, to a fracture or a brain injury or whatever. No, I see that kind of problems myself. So we need to make a case formulation that is sensitive to the context and the nuances of each case. So suffering is not necessary, although it's the most common, and we need to be sensitive to that kind of suffering in our patients when it is present. But the other point that you make is that with the same disease, some patients can have a joyful experience and others can have an experience of suffering. And what would be the scientific explanation of that differences? That is a great question. So myself, I would rely in the kind of neuropsychiatric formulation that I use that tries to look at all the facts, right? Sometimes there are facts of neurobiology, like the structural pattern of dysfunction or damage in the brain can lead to some persons to develop states of mania. We have the case of vascular mania. I see mania in the context of white matter disease. For instance, in multiple sclerosis, we can see patients with a lot of disinhibition, and sometimes they will have this effect that classic texts would call moria, or other patients will have anosodiaphoria, like Mario Mendes calls it, which is a kind of indifference, affective indifference towards the problems that are coming about with the illness, right? Dr. Mario Mendes studies this in the context of frontotemporal dementia, right? So patients with frontotemporal dementia can engage in a lot of problematic behavior for their relatives, but unfortunately, if the symptom of anosodiaphoria is present, the patient can have an attitude of indifference to those problems. So sometimes the neurobiological picture, the neurobiological pattern, the functional anatomy and so on can give us some clues to understand the difference in mood and attitude. But sometimes we need to focus on the personality of the patient, the psychological resources that have been developed through a history of interactions, a history of learning. And sometimes we need to focus also on the context and the cultural context of the patient that also imposes some constraints for emotional expression. So this kind of formulation is not a reductive one, but is, as I said before, a systemic formulation, because it acknowledges the physiological facts, the psychological facts, the cultural constraints, and tries to put the picture together. But of course, then we would have the problem of integration. How do we integrate that in a unified scientific picture? That is not easy, of course, but we still have the resources of cultural neuroscience, social neuroscience, cognitive neuroscience, and so on. So I think that this is a challenging and ongoing scientific project, not only for yourself and myself, but for the whole field of neuropsychiatry and clinical neuroscience. And my own thought about this is that this process of research needs to be systemic, not reductive. I see this perspective, systemism, as an intermediate way between holism and reductionism. Reductionism tells us that we need to seek the explanation in the parts. And holism looks at the broader picture, the behavior of the whole agent or the whole system. But a systemic approach acknowledges both the emergent property of the system and the properties of the part. So I think that's our best approach so far.